Good afternoon, everybody. Like you all, everybody sitting in the house, I also favor Glitazone strongly. No financial disclosure, no shares of any company making Glitazones belong to me. We all know what an ideal anti-diabetic drug should be, and we'll see whether Glitazone passed those tests or not. As on dosiglitazone and will restrict myself only to pioglitazone. Whether we talk about the triumvirate, that is three-tier pathogenesis, or we talk about ominous octet, or we talk about dirty dozen that we see, everywhere you see beta cell exhaustion and insulin resistance as the prime mechanism of action. And if somebody asked me what is the drug that directly acts on the insulin resistance, which is the primary pathophysiological mechanism, the answer would be glitazones primarily and metformin secondarily. All the statements that are coming in the few slides are narrated by references which are the best relevant references, and the ones that are highlighted in red are those that have come after the glitazone controversy, that is cancer controversies. So this is the first drug to date which targets the insulin resistance. Remember, sitagliptin or exenatide in duration 4 study clearly suggested that they do not target the primary pathophysiology. And for that matter, SGLT2, that is the newer drug that is coming, is also not doing the same. Efficacy, lots of trials, hundreds of trials and thousands of papers have come out and suggested the excellent efficacy of glitazones. Compared with metformin in quartet trial, reduction of HbA1c 1.5 as much as metformin. Compared with sulfonylurea, significantly better durability with glitazones. Compared with DPP-4 inhibitors, the new hero these days, superior to DPP-4 inhibitor sitagliptin. In fact, this is the conclusion of a study by sitagliptin producers. In combination, can be combined with all other groups of medicines and excellent combination efficacy. Lipid friendly, improves HDL, reduces LDL. Importantly, reduction in blood pressure. Everybody knows consistent reduction in blood pressure by 3 to 5 millimeters. Somebody can ask, just 3 to 5 millimeters? Remember, 3 to 5 millimeter blood pressure reduction reduces stroke by 22%. And Ramipril, the most wonderful drug, in its gold standard HOPE study, reduced blood pressure by 3 millimeter at the dose of 10 milligram. Beneficial effect on microalbumin, which is never seen with metformin or any other sulfonylureas. However, we do not say that we should not use sulfonylurea and metformin just because they don't act on it. However, there is a positive effect on microalbumin. All biomarkers and surrogate markers, beneficial effect. And when you compare 4 important drugs, that is secretagogues, metformin, glitazones, and AGI, that is acarbose or voglibose, all standards suggest the positive effect of glitazones. Yes, apart from acarbose and metformin, this is the only drug that has been used in cases of prevention in huge trials with excellent results of as much as 72% prevention of progression from IGT to diabetes. There are few things that always come to our mind. As soon as we talk about myocardial infarction or heart attack, we start thinking that pioglitazone should not be used. A few words about proactive trial. It was a large prospective randomized double-blind trial. And look at it. 50% of patients had previous MI, 25% had previous stroke, and 25% had PAD. All patients were high-risk coronary artery disease and previously documented coronary artery disease. And the dose of glitazone used here was 45 milligram, which we do not use these days. And what was the outcome? Look at this. 28% reduction of subsequent MI, then 48% reduction of second stroke, and once again, Chicago trial suggested carotid edema media thickness reduced. When compared with glimepiride in periscope trial, once again, significant lower rate of progression of coronary artery disease. So one can very easily say that it works on heart, brain. It also works on liver and ovary, which is not the situation here. Look at the guidelines, all guidelines. For example, the guideline of our own guidelines 2012 shows primary and secondary drug as glitazone. When we talk about ADA, once again, in combination or as a primary drug or a monotherapy glitazone, AAC guideline once again shows glitazones at all 3 places And once again, when you look at pathophysiological guidelines, once again, glitazone shine out. Similarly, nice guidelines suggest glitazones at all levels. Cost of medicine is always a problem. And look at the cost of medicine. I'm talking about 30 milligram of pioglitazone, and it is the most economical of all other available OHs. Then we go to the further thing. Yes, pioglitazone is a rose having some thorns. And what are those thorns? Fractures, heart failure, anemia, macular edema, and bladder cancer. Edema. Just 5% of people develop edema when used as monotherapy and 10% when used with sulfonylurea or insulin. And remember, amlodipine has edema as much as 12 to 15%. Weight gain with pioglitazone is totally dose dependent and does not occur as much as with 15 milligram as you see with 45 milligram. Yes, proactive study definitely suggested that there was an increased heart failure incidence. But remember, the heart failure is basically an outcome, a common complication of type 2 diabetes as much as 12 to 20%. But despite that fact, the overall mortality, total cause mortality was much less. And remember, those patients who developed heart failure, the rate of hospitalization was much less. Remember, gliptins have high incidence of hospitalization with heart failure. And we never say that we should not use gliptins. Bone fractures with pioglitazone, yes, it has been very, very much talked about and discussed about. But look at the incidences, 0.5 fractures per 100 patient years in females, elderly females. This is as much as similar to that seen with several other widely used drug classes. And in men, it is less than placebos. Macular edema seen only when it is utilized with insulin and reduces with AC inhibitors and aspirin, which we commonly utilize. Anemia. Anemia is seen only in 1% of patients on pioglitazone. HB is reduced only by 2% and seen within 4 to 12 weeks of initiation of therapy, then it stabilizes. So it's never a problem for drug withdrawal. Bladder cancer, lot has been talked about. Just as our chairperson recently said that the dilemma is practically over. I don't see a futile discussion on bladder cancer because the company itself has now given a 10-year observational study, which is the longest ever, even longer than the glargine, and it has shown no bladder cancer association. However, diabetes was associated itself with 50% increased risk of bladder cancer. And this is 2014 Cleveland study report, which suggests that 25,613 patients, when they were followed up in female, the 32% decreased risk with, as compared to sulfonylurea, and 21% decreased risk of cancer when sensitizers were compared with the secretagogues. It has been clearly said now US FDA and other health agencies have reviewed all available data and concluded that pioglitazone has a positive effect. So all in all, just before finishing, Indians as an ethnic group have high insulin resistance. We heard a lot in the previous debates also. At this moment, we have got clinical data by which we can diagnose insulin resistance like waist circumference, low HDL, and fatty liver and whatnot. And these are the groups of people where pioglitazone is excellent. All those patients who are suffering from previous pre-existing cardiovascular disease or coronary artery disease with good LVEF, excellent drug. And remember, all newer drugs are being compared with pioglitazone, as we have seen in duration studies or in SGLT2 inhibitors. So, there is an excellent article in 2013. Do we still need pioglitazone for the treatment of type 2 diabetes? My answer is, we still need available glitazone for the treatment of type 2 diabetes. I'll keep 2 minutes for reboot. Thank you very much.
Thank you, Dr.